disease. In this first part of Part 1 integrity, we will talk about definition of coronary artery disease, the classifications of coronary artery disease and the definitions of that, risk factors and causes, and treatment of coronary artery disease. Coronary artery disease can be classified into either chronic stable angina pectoris, which is chest pain in the heart muscle, acute coronary syndrome, and that's further divided in unstable angina, ischemia, and myocardial infarction. And we'll talk about these on into the integrity. With coronary artery disease, the main cause of coronary artery disease is plaque in the coronary arteries. Arteriosclerosis and atherosclerosis is used lots of times interchangeable. Mainly, arteriosclerosis is a thickening of the walls of the arterioles with a loss of elasticity and contractility. Atherosclerosis is an abnormal accumulation of lipid or fatty substances in fibrous tissue, creating blockages or narrowing of the vessel. That is what causes a lot of this thickening of the walls of those arterioles and the loss of that elasticity and the contractility of those vessels. When they start getting some accumulations of those lipids and fatty substances. We'll talk about that further as well. Here's your coronary artery, a picture of your coronary arteries. The coronary arteries come off of the aorta. They feed the left and right side of the heart, anterior and posterior. Blood rushes into those coronary arteries on diastole. When the heart is in diastole, most of all the oxygen, except for about 25%, is used up by the muscle tissue. So that just tells you that the muscle and cardiac tissue has a high demand of oxygen. So anything that slows that oxygen or completely blocks that oxygen is very detrimental to the cardiac tissue. Most definitely, if you have a lack of oxygen to the heart, it does cause pain. It causes chest pain. It can cause angina pain, ischemia to the heart. This is a breakdown of how a clot forms, or that plaque formation in the coronary vessels. You see on the left side that there are some risk factors. We'll go over those again. The very inner lining there is the endothelium. That's a very protective lining of the coronary vessels. If you damage that endothelium in any way, that increases for cholesterol to come into that area and start gathering there. They like to lay there. They think that's a good place to gravitate to when they're in the vessel, is any break in the endothelium. That's why cigarette smoking and tobacco use is considered a high risk factor, because all of the different chemicals in tobacco causes the endothelium to be damaged. Also with diabetes, we know that diabetes also damages the endothelium, and when the endothelium is damaged, there's more plaque gathering there. It's not a smooth surface anymore. You'll see here there's a little plaque that started, and you'll see that right in here as it progresses, it builds up a little bit more. They consider that a fatty streak. When that happens, our body tends to throw platelets, they throw white cells, myocytes, macrophages to eat that cholesterol or that plaque off. They sense that as being foreign. They sense that as not being good to your body. So they're trying to get rid of it. But what happens is these little macrophages tend to eat up the plaque and get so full it causes them to get so full that they die off. And that just adds to the plaque because those dead cells sit there. So it gets to be quite a bit of formulation after all of this happens, of all these different cells that runs and races to try to get rid of the plaque. Then there's some fibroblast as part of another thing that comes to the rescue. And in that, it throws over a cap, like a fibrous tissue, over the top of it. And being that they don't want that to go anywhere, that's what those fibroblasts are trying to do, put some fibrin over it where it's not going to go anywhere, hopefully. But as the blood rushes across it and there's and this gets to be a bigger and bigger plaque and the rush of blood and hypertension, say, then it can actually rupture that area there. And when it ruptures that area, it may rupture it totally where it turns into an emboli, and that's when it can actually travel into the heart and cause an MI, or it will partially rupture and cause a sort of like a flap. So if it ruptures right along here but not down here, when the blood rushes, it tends to just flap it. That tends to flap back and forth. And when it flaps back and forth, that's when you get a lot of angina. You get a lot of unstable angina too, because at certain times it'll be open and then at other times it will not. So this is the formation of that plaque in the vessels. Now, it is very important for us to note as nurses that we have to have our lipids, our cholesterol at a certain level in our body. When we have high levels of that, that's what causes these plaques formation more so. So for total cholesterol, desirable is 200. High would be anything over 240. LDL is considered lousy, or I call it lousy because it starts with an L. It's the bad cholesterol. For optimal, we want to, excuse me, for optimal, we want to keep that under 70 or under 100. If someone has high risk factors, then we want to keep them under 70. If they have moderate risk factors, then we want to keep them under 100. But anything as it goes, you see that above 190 is considered very high. So we also, our lipid levels, we're wanting to look at those. And those are that is the good cholesterol. It's HDL, I call it the happy cholesterol. The happy cholesterol is the good guys. They actually that cholesterol cruises the bloodstream and removes the harmful, the LDL, the bad cholesterol. So high levels actually reduce the risk for heart disease if you have good HDL. Low levels, on the other hand, actually increases the risk of heart disease. Along with other things, there's many other risk factors like exercise, a lack of exercise, or things like that. Obesity and smoking that can cause that. We'll talk about that later. But most definitely, we would need to teach our clients who have risk factors that, or just anyone, or that about heart disease, that we need to keep these levels at the optimal level. Here's the triglycerides. And you see that normal would be under 150, and that goes all the way up to over 500. And then you can see the borderline high and the high triglycerides in between. So for chronic stable angina, that's one of the classifications of coronary artery disease. That definition of that pretty much is the chest discomfort that occurs with moderate or prolonged exertion in a pattern that is familiar with the patient. In other words, it's something that they're used to. They understand that they get this, and it is due to a plaque. It's caused by a fixed plaque that causes a temporary imbalance between the myocardial O2 and demand and the O2 supply that the heart would need. Now, the patient is, like I said, when they become familiar with this, they understand if they rest, sometimes it goes away on its own, or they can take nitroglycerin, and that will help, and it's usually always helped by that, by those things. And that's what they do for it. There's some treatment, like I said, the rest and nitroglycerin. They can even give some patients some beta blockers and calcium channel blockers as far as and aspirin and Plavix as well. With unstable angina, although that gets into more of an acute coronary syndrome. So that's the first thing. You see this progress, and the first progression after the stable angina, you get into the acute coronary syndrome, would be the unstable angina. That's when they have chest pain that occurs at rest or with minimal exertion. The pain may last longer than 15 minutes. It may be poorly relieved by nitroglycerin. Between 10 to 30% of patients with unstable angina progress to having an MI in a year, and 29% can die of an MI in 5 years that present with this unstable angina. There is a chart in your chapter that distinguishes that between the two, and I think I have one on this slide as well. With unstable angina, it could be a new onset angina. In other words, they can be having angina, just stable angina and alone, and they need to understand and be educated on what would be the difference between just that and stable angina, because once they start getting the unstable angina, they get at higher risk for an MI. So new onset angina is just that. Someone is just beginning to have that symptom. And as you know, the clot has been there forming for a while, or the plaque. So, and there's probably some sort of a rupture there. And like I had said in the earlier slide, many times it's partially ruptured, and because it sort of flaps back and forth with blood flow, it can make a higher blockage, which throws it into a whole different arena from stable to unstable. With unstable angina, you may see EKG changes at this point as well. But there is also Prince-Metal's angina. Now, Prince-Metal's angina occurs at rest, usually in response to a spasm of a major coronary artery. This is not something you see a lot of. It's more rare than anything else we're talking about here. But the spasm can occur with an absence of any coronary artery disease. So you can have Prince-Metal's for different reasons and different disease processes that someone may have that would be considered angina, but can or cannot be associated with coronary artery disease. Pre-infarction angina is just that. once that just tells you that um, the patient is having more frequent attacks, and many times not controlled by nitroglycerin or any other drug. Um, the chest pain may last longer. It's a red flag before an actual MI or ischemia takes place. Um, so pre-infarction angina. Now, this angina can begin to cause some ischemia. Ischemia is just um, a lack of oxygen to the heart muscle. It's a lack of oxygen because of a partial or complete blockage. It may take it may not be very long after ischemia that they have an MI. These are the unstable angina versus MI. It tells you the difference in the symptoms. It usually is it's usually 5 to 15 minutes. They have many of the same symptoms with unstable, but it's more severe with MI. Relieving measures can be rest and nitroglycerin and oxygen. They do have shortness of breath and dizziness and nausea, so they have it's starting to mimic a lot of MI type of side effects. But the nurse would never be put upon to diagnose between an unstable angina to a myocardial infarction. There will be a team of people in the ER wherever you're practicing that would have an incoming patient who has an MI, with EKG readings and expertise of physicians, they can distinguish with that. But just for the nurse's sake of knowing that there's much difference between an unstable angina and the myocardial infarction, even though they mimic each other quite often. So again, acute coronary syndrome is classified into those classifications. It can be classified as unstable angina, then ischemia, and those can be further divided into ST elevation MI, non-ST elevation MI, and unstable angina. Now, the definition of coronary artery disease, I should have told you that on the first slide, and this is just straight from your book. It's a diseased arteries, coronary arteries that supply the heart with blood, and therefore it affects the pumping of the heart, and enough blood is not being pumped to adequately perfuse vital organs and peripheral tissue. That's straight from your book. Now, I will be going over in a different integrity about ST elevations and dysrhythmias, but here's just a picture of what I'm talking about. Here's the zones of ischemia. You may see a T wave inversion when you see ischemia. It's not an MI quite yet, but then an MI happens and there's a zone of injury. It actually damages the cardiac tissue. With that, you will see an ST elevation. So you have your P wave over here that's not shown. QRS, how it comes down. Well, you have QR, and you see it doesn't quite come down to that T. ST is elevated there. For any old necrosis that you might see, you will see an abnormal Q wave right here. So you may see that deflected in a negative manner. So these are the different things you may see on an EKG for coronary artery disease. For those coronary artery disease, there needs to be a blockage of about 40% in their coronary artery before it starts to really block blood flow. The percentage of blockage will really lead to the amount of ischemia, necrosis, and symptoms that the patient may have. Myocardial infarction occurs when the myocardial tissue is abruptly and severely deprived of oxygen. Ischemia develops when the blood flow is reduced by about 80 to 90%. Infarction is a dynamic, so when I was saying 40%, the blockage starts at 40%. The ischemia will start at about 80 to 90%. Infarction is really a dynamic process that does not occur instantly, but evolves over a period of several hours. And we saw that on the slide before, where you saw the different zones of ischemia all the way down to damage, then even to necrosis, and we saw the changes in that ST and all. So that it happens over several hours. So the etiology then of a myocardial infarction is a rupture of a plaque in a coronary artery leading to the development of thrombus and occlusion of that coronary artery. Now, the Prince-Metal spasms can cause, rarely though, if it just keeps on and on and on, to have a blockage in a coronary artery. Or there's platelet aggregation or thrombi that can cause that. So it's just basically that it's being blocked off, that it can no longer get enough oxygen to supply that part of the heart. It damages that part of the heart, and that heart begins to have damage. Now, being that we know that it's a dynamic process, that's why it's critical that nurses and doctors start taking care of these patients as soon as they hit the door, or as soon as the EMS get to them. We want to start that reperfusion on these clients as soon as possible. Damage can be turned around if we can get reperfusion, say with thrombolytics and other reperfusion treatments, to get that to the patient in a time that damage has not occurred, because we realize it's a dynamic process. It happens over hours, and there can be interventions that can decrease the damage to the heart. The infarction can begin in the subendocardial layer, but it can progress to all three layers, which would be considered a transmural MI. Now, once that damage continues in the heart, to the heart muscle, then and it necrosis, it goes through all those stages, which is well written in your EE book. It really can cause a remodeling of the heart. Your heart muscle is scar tissue. Once it starts healing, it's not the same size or structure it used to be, because we know how scar tissue can affect that, and that is what leads to congestive heart failure, is a remodeling of that heart from an MI. We know now, just a note here, we know that CHF in an MI, chronic heart failure, is different than myocardial infarction. Heart failure is when the muscle has been remodeled and it can no longer pump enough blood to the rest of the body. So it's not a efficient pump anymore. And so that can be to different levels, that depending on how much damage that heart has. All the way to the MI. The MI is actual damage to the heart muscle. That's what we're talking about that. So heart failures where it's not pumping well, and MIs where there's been heart damage, and we're going to try to treat that as best we can. Now, you just need to know that the patient, first line of treatment for coronary artery disease, is diet. That is the best thing to do if they can change their diet. What they pretty much say as far as a diet in the American Heart Association is to decrease the saturated fats, and that lists to have less than 7%, and polyunsaturated fats, and monounsaturated fats. The saturated fats, of course, is really bad for you, of all those fats. So the total fat should be no more than 25 to 35% of your total calories. Carbohydrates, they suggest to have complex carbohydrates, including whole grains, fruits, vegetables is what they ask for people to have for a good cardiac diet, a healthy heart. Also, to lower our cholesterol and to have less than 200 milligrams a day of cholesterol, to have about 15% of total calories in protein. They want fiber is good. That helps clean your vessels, so they're asking for 20 to 30 grams a day on that. And then also we need to watch our weight by not having a high calorie diet every day, and having at least some moderate physical activity in combination with that. Lifestyle interventions for them would be to teach them to eliminate tobacco use, and like we said, we saw where that damages that endothelial layer of the coronary arteries, so that's what causes a lot of these plaque buildups. Increase their physical activity. Increasing physical activity helps reduce your weight, plus it helps with HDL, that happy cholesterol that we had talked about earlier. And physical activity helps make more of good HDL. Manage our hypertension, most definitely, because once those plaques start growing and they're hypertensive and it's not well managed, then that causes the clot to either slough off and move as an emboli, or to rupture, and also it causes more workload on the heart, which needs even more oxygen. Manage the diabetes mellitus, has as much the same damage as tobacco use on that inner lining of the coronary artery. Manage weight. Obesity is definitely a risk factor for coronary artery disease. They ask to decrease the consumption of alcohol less than 3 ounces daily, although there are some studies that say some alcohol can be beneficial to the heart, especially wines, especially red wines. And stress is considered to be a risk factor as well. And depending on how few and how many of these, you may not have any of these, but you have stress, you would be at a mild level risk factor. Two or three or more of these can be moderate to high risk factors. Now, stress can release catecholamines, which catecholamines can cause, again, more stress on the heart, more workload on the heart, and other things in the body that can cause coronary artery disease. Now, they try to intervene with lifestyle changes. They try to intervene with diet. They can put them on statins and other drugs that's listed here, but they have a lot of side effects. So you can look those up in your book. But statins like Mevacor and Lipitor can be used. That helps just reduce the levels of cholesterol. Other drugs like Tricor or Zetia can actually cause can reduce the absorption of absorption of cholesterol in your body. So that's one thing that it can do. That's done for the small intestine as well. And then there's combination drugs if they can give them, and that has two different uses. Reduces the absorption of cholesterol, and it decreases the amount of cholesterol synthesized in the liver. So, just to know that, they can have a combination of some of these drugs, especially the statins and the Tricor and Zetia. They can combine those with some patients. And that is all of the coronary artery disease integrity. Thank you.